I was, as I said, I was asked to talk about hepatitis B infection, and the specific title was Emerging Concepts in the Diagnosis and Management. So I guess it's customary to show the seroprevalence of hepatitis B around the world, and the ones in red are the endemic countries, and we are in red. Our estimated seroprevalence as of 2003 was about 16.7% of Filipinos. So that's actually 1 out of 6 to 7 adult Filipinos have hepatitis B infection. So I'm sure there's a couple in the room. In fact, our fellow just did a survey of prenatal women who went for prenatal checkup, and the seroprevalence that we got from that survey of more than 700 women was about 10%. So I think seroprevalence of 10 to 15% is probably a safe estimate. And why is hepatitis B a public health problem? It causes cirrhosis. About 15 up to 40% of patients with chronic hepatitis B will develop cirrhosis and end-stage liver disease, requiring liver transplantation, or in the absence of which they will die from the complications of hepatitis B. So this is just a slide to show you what has happened in the field of hepatitis B in the last half century, since its discovery, the discovery of the Australia antigen in 1965, and that netted a Nobel Prize, and then to the discovery of the oral agents in the 2000s. So I'm not going to talk about what has happened in the last 2 years because the title was Emerging Concepts. So I'm going to be talking about some new things that may not be particularly standard of care, but they're very exciting and they're being studied more extensively. So just an outline of what I'm going to go through. I will talk to you about hepatitis B genotypes and their clinical significance, and HBs antigen quantification and their clinical significance, non-invasive assessment of fibrosis in chronic hepatitis B, and some aspects of treatment, and I have to include advocacy. First we'll talk about hepatitis B genotypes and their clinical significance. This is a map that shows the global distribution of HBV genotypes. So there are 8 recognized genotypes, and these genotypes differ from each other by more than 8% of their complete genetic sequence. So they're different based on their genetic sequences. And the genotypes of a particular geographic distribution, so in the Asia-Pacific region, especially in East Asia, Japan, Taiwan, Korea, is genotype E and C. But in our country, it's actually genotype A. It's similar to the predominant genotype in Europe as well as in North America. And these are surveys, small surveys done in Manila as well as in Cebu. And the clinical significance of hepatitis B virus genotypes is still undergoing refinement, but it seems clear that hepatitis B genotype B infection has a more benign course because there's higher rates of S antigen loss, which means there's clearance of the hepatitis B infection spontaneously, and there are less rates of complications such as cirrhosis and liver cancer in genotype B infection. And treatment response is also better in patients with genotype B infection as well as genotype A infection. So I think the take-home message there is that genotypes A and B compared to genotypes C and D are more favorable genotypes of hepatitis B. So then we'll go to hepatitis B surface antigen quantification and its clinical significance. As if we didn't have enough to worry about, to understand on hepatitis B serology, this is one of the major stumbling points, I think, for clinicians is the number of serologic tests that we have to go through and interpret for hepatitis B infection. But we are going to add another one, and that is hepatitis B surface antigen quantification. This is not the HBsAg that you see in the report. That's a qualitative report. You have to specifically ask for this, and this is a quantification of S antigen levels. So this is actually not an old a new test. It's an old test, but it was very, very labor intensive and expensive before. But it's recently been automated, so now it's easier and it is finding increasing use in clinical practice. It has found its way finally to the European guidelines, but it has not yet been adopted by other societies. So what are the potential uses of S-antigen quantification? So one is the prognostication in the natural history of chronic hepatitis B infection. In particular, it can help us differentiate a patient who is an inactive carrier from a patient who has e-antigen negative but very active infection. And it can also help us risk stratify patients with hepatitis B as to their risk for developing hepatocellular carcinoma. And it's also now being used by many clinicians as a monitoring tool during therapy of chronic hepatitis B infection, especially those who are being treated with pegylated interferon. So this is a slide that is familiar to many of us gastroenterologists, but I don't know if it's familiar to everybody else. But these are the 4 phases of infection, or in this slide there are 5 phases because it includes the S clearance phase. But most of us in the Philippines who are infected during childhood go through all of the phases, but we stay in the phases in different, with varying durations. So meron mabilis lang sa isang phase, diretso na sa isang phase. So the particular use of S-antigen quantification is in these 2 phases because these are both E-negative phases. So these patients have HBe antigen that's non-reactive, but they're very different groups of patients. The immune control phase, or the inactive carriers, have very low risk of developing severe liver disease, so they are not treated. Whereas the patients who have e-antigen positive chronic hepatitis B have active liver disease, and thus will need treatment to prevent the development of cirrhosis, liver failure, or hepatocellular carcinoma. And if you notice, if you notice, if you just have one determination in a particular patient who may be in this phase of infection, it may be that they resemble very much the patient who is an inactive carrier because their DNA levels are very low and their ALT levels are very low. So it's very difficult to say whether the patient that's in front of you right now is an inactive carrier or is someone who is a very active e-antigen negative chronic hepatitis B patient. So the particular use of S-antigen is that it might be that if you're faced with such a patient who has a normal ALT and a DNA that's less than 2,000, you can get an S-antigen level. And if the S-antigen level is less than 1,000 IUs per ml, then that patient is most likely an inactive carrier, and you can safely monitor that patient. Whereas the patient whose S-antigen levels are greater than 1,000 will need more closer monitoring. And if their ALT levels rise, they would need treatment with antiviral medications. So that's one particular use of S-antigen quantification. The next one is in terms of risk stratification for hepatocellular carcinoma. This is a slide that shows you the risk of developing hepatocellular carcinoma according to the level of HBV DNA. So it is well known that the DNA levels in a patient with chronic hepatitis B infection will predict the development of hepatocellular carcinoma in the future. So the higher the DNA level, the higher the risk of getting hepatocellular carcinoma. But there is a particular group here, the one with the arrow, where the lines actually do not separate. So is there another test that we can potentially use in this low viral load patients where we can say that some patients are actually at higher risk of developing HCC compared to others? So again, if you look at this 2 groups, the 2 lines, HBV DNA from 200 to 2,000 IUs per ml, and those with HBV DNA less than 2,000, you can order a S-antigen level, and and if they are greater than 1,000 IUs per ml, their risk is higher compared to those who have S antigen levels less than 1,000. So it's just trying to further refine the way we can risk stratify our patients who have low viral loads of HBV DNA. And then lastly, in terms of its utility in monitoring treatment response with antiviral treatment for hepatitis B, this is a particular example of patients being treated with pegylated interferon. And if you look at the left side, you will see that if you look at the sustained responders and the relapsers, their DNA levels during treatment actually do not differ. So you cannot use the DNA levels to predict response or non-response. But if you look at S antigen levels, which is on your right, the S antigen level determination can actually determine or differentiate your relapsers from your sustained responders. So much so that many clinicians will use the S antigen levels during treatment with pegylated interferon at certain treatment time points, for example, at week 24. And if the S antigen level is still greater than 20,000, here, they will say that because if the S antigen level is still very high, you can stop treatment at this time because continuing treatment will be futile and it's just a waste of money and exposing the patient to more side effects of the interferon treatment. So that's one of the uses now of S antigen levels in management of chronic hepatitis B patients, which is using them to predict response during treatment with pegylated interferon. And you can do that because pegylated interferon therapy with hepatitis B is 48 weeks. So you can check at 24 weeks and decide if you should continue treatment or you should stop treatment because the likelihood of response is very low. Then I've just touched a little bit on non-invasive assessment of fibrosis in chronic hepatitis B. And the reason is that fibrosis is the main reason for the morbidity and mortality of hepatitis B and also in any form of chronic liver disease. And the gold standard to determine fibrosis is liver biopsy. But liver biopsy, I don't know how many of your patients will agree to a liver biopsy. It's poor acceptability. It can be costly, and there are potential complications, as well as there are sampling errors in about 15 to 20%, because the amount of tissue that you get is very small compared to the size of the liver. So there has always been a search for non-invasive ways to test for fibrosis, severe fibrosis or mild fibrosis, and these are some of the candidate non-invasive tests for fibrosis. Serum fibrosis panel is not available in the Philippines, and MR elastography is too expensive and also not available in the Philippines. What we have is transient elastography, better known by its brand name, which is FibroScan. And this is the machine of the FibroScan, and on the right is the probe that we use. It's really almost like an ultrasound, and it emits just a pulse wave, so parang hangin lang sa side that's how it's done, on the side where the liver is. And then it just parang may mga blows hangin dito sa right side. And what it measures is the liver stiffness in kilopascals. And the higher the kilopascals, or the higher the liver stiffness, the more fibrotic the patient is. So for example, here in this example, if the liver stiffness measurement is 3 kilopascals, there is no fibrosis. And if it's 9 kilopascals, there's significant fibrosis. And definitely with 40 kilopascals, that's a patient with cirrhosis. And how can we use that in our patients with chronic hepatitis B? So this is one management algorithm using the transient elastography technology, and this is from the UK. I don't know if it's called the NICE or the NICE guidelines, but they start with a FibroScan determination first. If the FibroScan test shows very high liver stiffness measurement on the right side. Even though the DNA levels are very low, as long as they're detectable, they would recommend treating those patients because the patient already has evidence of liver disease or advanced fibrosis. And for those with lower liver stiffness measurements, then they use and stratify them according to their HBV DNA levels as well as their ALT levels. So that's one way that transient elastography for the FibroScan technology can be used in managing patients with chronic hepatitis B infection. Transient elastography is available in several centers in Manila. It's also available in Davao, actually. So moving on to treatment, we've looked at diagnostics. Currently in the treatment of chronic hepatitis C in 2015, we have the interferons and the oral medications. There's 6 oral medications available, and we have mostly treated our patients with monotherapy because most of the studies on combination therapy have not done very well in terms of their results, and monotherapy seems to work as well. But recently, although this is not yet fully published, a study that looked at combination of interferon and an oral agent, in this case tenofovir and pegylated interferon, compared to tenofovir alone and pegylated interferon alone, was reported. And as you can see from their results, the S antigen levels are lower at treatment week 48 in the combination arm compared to all the other arms, the monotherapy arms and the delayed introduction of pegylated interferon arm. So sort of more exciting data on combination therapy, because if you think about it, in any viral infection, combination therapy attacking different pathways of the replication of the virus should really work like what they do for HIV infection. And one more result for this trial, the S antigen loss, which is really what we consider to be almost as close to a cure in hepatitis B treatment, is higher in the combination arm compared to all the other arms in this particular trial. So if this finds its way into full publication, maybe this will be adopted. This will be a strategy that can be adopted for hepatitis B. Now, I wanted to show this slide showing the natural history of chronic hepatitis B infection. As I mentioned, most of the morbidity goes through cirrhosis and then the development of HCC and end-stage liver disease. So therefore, anything that we do to prevent cirrhosis formation or even reverse cirrhosis would be helpful in our patients with cirrhosis and hepatitis B. So the question then is cirrhosis in chronic hepatitis B reversible? And I think if you remember from medical school, we were told if you had cirrhosis, that cannot be reversed. But it may not be necessarily true in all patients. So this is an example of a patient with, this is actually for hepatitis C infection, but before treatment on the left, you see this nodule and these broad bands of fibrosis. And 6 years after clearance of the virus, you see normalization of the architecture, the disappearance of the inflammatory infiltrate, and then the broad band of fibrosis has disappeared. It looks like a more normal liver. So it appears that cirrhosis is reversible in some cases. So let's look at some data for hepatitis B infection, because we have had experience with the good oral agents for more than 5 to 7 years now. This is data for entecavir, which is one of the 2 recommended oral agents by the WHO. Small numbers, 10 patients, and 100% of those patients with cirrhosis actually had improvement in their fibrosis. Some of them as much as 3 fibrosis points out of 6. So that's a very significant improvement in fibrosis stage with 5 years of treatment with entecavir. The other oral agent that is recommended by the WHO is tenofovir, which, by the way, is an HIV medication, but that works also for hepatitis B. And this is a much larger group of patients with cirrhosis, And as you can see from this slide, more than 72% of patients after 5 years of treatment with tenofovir actually show improvement in their cirrhosis. That's a very remarkable number of patients with reversal of fibrosis. And as some of them decrease their fibrosis stage by more than 4 points. So the fibrosis staging is from 0 to 6. So these are patients with stage 6 fibrosis, and so some of them going all the way down to stage 2 fibrosis with 6 to 7 years of tenofovir therapy. I showed this slide on the HBV life cycle just so that to introduce the topic, although I really am not very familiar with the new drugs because they're all in preclinical and phase 1 to 2 trials. And this is just to illustrate some of the pathways that we can harness to treat hepatitis B infection, because currently we're just really using HBV polymerase inhibitors. But we can potentially have entry inhibitors, the small interacting RNA molecules, HBs antigen release inhibitor, and then the nucleocapsid formation inhibitor. And so these are just the emerging antivirals for chronic hepatitis B. And as I mentioned, most of them are either in the preclinical phase or the phase 1, phase 2 trial phase. Not in the life cycle or the immune-based treatment. And these are either therapeutic vaccines that are going to be given to patients with chronic hepatitis B infection. We will be starting a trial in the Philippines with a therapeutic vaccine, and we have 2 trials with therapeutic vaccine in E positive and E negative patients. So hopefully that this will give us newer medications that can handle hepatitis B. And lastly, I wanted to talk about advocacy because I think we're only seeing the tip of the iceberg in chronic hepatitis B infection. 16% of Filipinos, 1 in 6 to 7.5 million adult Filipinos to 10 million adult Filipinos. I don't know, we're not seeing that number of patients in the clinic. So I think we're just really seeing a small number of these individuals because maybe they're not being tested. A lot of patients do not have symptoms. And I think that hepatitis B screening is the first step in the road to a cure for many of our patients. So in order for us to use the many developments that we have in diagnostic and therapeutics, we need to be able to identify the patients with hepatitis B. And then the other part of advocacy is that we have safe and effective medications, but we need to make these medications accessible to our patients. So we need to try to harness the government resources to see if we can get them to agree to treat patients with hepatitis B infection. We also need to have capable practitioners who understand the treatment of hepatitis B to handle the treatment of patients with hepatitis B. But there's really a lot of things going on, and it's very exciting because the WHO, for the first time, is going to address viral hepatitis in a big way, beyond vaccination, because for the longest time, it was just hepatitis B vaccination. That they issued 2 World Health Assembly resolutions already in 2010 and in 2014 for member states to come up with comprehensive programs for hepatitis B. They in fact set up a global hepatitis program and has a document on the framework for global action for viral hepatitis infection with the 4 axes that are shown on this slide. And more importantly, the first WHO guidelines on hepatitis B infection management was launched in March of 2015, and it's very a useful guideline, especially for resource-challenged settings, because it's not only evidence-based, but it takes a public health perspective, very different from the perspective of the different professional societies with their other guidelines. So that's available from the WHO website if you are interested. It's a very thick document, but there is a summary. I think there are about 8 pages of summary that's very useful already. So in summary, there have been significant improvements in the management of chronic hepatitis B over the past half-century, and there are more developments recently in diagnostic testing, in prognostication, and in treatment. But I think we need to strengthen the advocacy to address the problem of chronic hepatitis B fully. Thank you very much. I wanted to make a plug, a shameless plug for our information campaign, our Be Aware campaign for hepatitis B. It's really for the day, but if you are interested, you can share it with your patients. Currently, the Facebook page is up. It's called Be Aware PH. And the website should come up within the next 2 to 3 weeks, and it's also beawareph.com. Thank you very much.